Good morning, Chase. Can you hear me?
Yes, I can, Christine.
Okay, wonderful. I'm not sure if I was having technical difficulties or not. Thank you again for everyone joining us today. I'm going to turn today's presentation over to our speakers, Chase Malaya, our in-house counsel and director of regulatory compliance with Health Current, and Melissa or Mel Solis, who is one of our partner at Coppersmith Brackle Med PLC. Chase?
Great. Thank you, Christine. And thank you, everybody, for joining this morning. And I see a number of our Health Current staff and others. So we really look forward to having this discussion and talking today about the ONC and CMS interoperability rules and doing a primer and a deep dive on information blocking. So let's get right to it. If I can click through here and talk about today's agenda. So as you may know, there's a lot of action happening at the federal government, and we've seen two rules from the Office of the National Coordinator for Health IT, or ONC, and CMS, the Centers for Medicare and Medicaid Services, and they have released these rules that are really going to change the health IT ecosystem. And so here's our agenda to kind of help us walk through what it looks like for healthcare providers and what those class of organizations need to know about these rules. Primarily, we're going to do a deep dive in information blocking. That's this new concept that you may have heard that really changes the way the sharing of health information will be regulated. And Mel's going to help us do a deep dive in that. And in addition, we're going to talk about the CMS conditions of participation and other incentives that are being promulgated by CMS to encourage their regulated entities, so hospitals and health plans, to make their data more readily available. So without further ado, I'll introduce Mel. Mel is our outside counsel here at Health Current, and she works all over the country and advises HIEs on how to comply with the variety of complex issues around the sharing of health information. So Mel, do you want to get us started on what healthcare providers need to know about the information blocking rule?
Yes, let's talk about the information blocking rule. And Chase, would you go ahead and continue navigating the slide deck for me? Thank you.
Sure.
We are really seeing a fundamental shift in this industry on how we think about sharing electronic health information. For decades now, since the 1990s, HIPAA has been telling us how we may share health information. With a few exceptions, HIPAA doesn't mandate the sharing except for certain patient access rules. The rest of the rules are permissive, so it allows healthcare providers to share information, but it doesn't require you to. Well, now we're seeing a shift where the information blocking rule is going to tell us, or at least actors, including healthcare providers, when you must share electronic health information. And unfortunately, providers are really in between a rock and a hard place because you're facing big penalties or disincentives on the one hand under HIPAA if you get it wrong and you disclose when you shouldn't have disclosed, and then also penalties and disincentives on the information blocking side if you should have shared your electronic health information and you didn't. You go ahead and advance the slide for me, Chase. So before we get into the nuts and bolts of what does an information blocking claim look like and how do you tailor your practices so you can fall within a safe harbor to avoid disincentives or penalties if those apply to you, I want to talk a little bit about why we got this prohibition. It actually came out of the 21st Century Cures Act back in 2016. But the way Congress wrote the law, they really left it up to the Department of Health and Human Services, specifically ONC, to write the safe harbor for practices that don't constitute information blocking. And we only recently got those rules finally published in May of this year. So Congress's intent behind this rule that we now have today, back in 2016, was to accomplish a couple of things. Overall, the real goal here is to put patients in control of their health records, to make patient data requests easy and inexpensive, to promote innovation and competition in health solutions, which means for providers, it means freeing you up so if you want to change health IT vendors or health IT systems that you're using, you can do so without being trapped by opportunistic vendors who might make it difficult for you to move your electronic health information. And then probably most importantly for HIEs, to promote that interoperability, to allow EHI to move freely if it's permissible under the privacy laws. So let's go ahead and go to the next slide. I'm going to hand it back over to Chase, and Chase is going to walk us through kind of the nuts and bolts of when the information blocking rule applies, to whom does it apply, and what practices are we talking about, and then I'll walk you through some of the safe harbors. Chase?
Great, thank you, Mel. And I just want to give everybody kind of a fair warning with what the content we're about to go through. And I'll say that there is quite a bit of density here. We're going to talk about the application of the rule in terms of who it applies to, what information it applies to, and then Mel is going to help us really do a rundown of all the various exceptions that she mentioned earlier that ONC has created to the information blocking rule. But if we're going to do this rundown, and we're going to make sure everybody kind of gets this primer, but I do want to let everybody know that more content will be coming from Health Current. We do intend to do further of these types of webinars and other modules to further elucidate all the information from the various exceptions. So I say that all as a primer to say a lot of dense information coming your way right now, but please be, please know that we're here to provide more support where we can, and that information will be forthcoming as we generate it. Okay. So let's get back into the information blocking rule, as Mel mentioned. And we talked about this main aim is to really increase interoperability among the various healthcare stakeholders. So making providers to be able to be more flexible and move over to different vendors and being able to share their information among plans and patients having control. All these various aims are about making that data more available. Okay, so who is ONC targeting to encourage that data to be more interoperable? Well, they define 3 actors who the information blocking rule applies to, and it's listed those 3 bullets there. Healthcare providers, health information exchanges or health information networks, those are synonymous, and Health Current would be an example of those. And number 3, health IT developers of certified health information technology. Sometimes we'll hear that referred to as CHIT. So those are the actors. As you see, it's quite broad. One thing to note is that an organization may fit into more than one of these categories depending on what that organization does. So, of course, we know various health information or healthcare systems, hospital systems might have their own health information exchange, or they might have their own development shop where they are creating new software. In those cases, they might be different actors for certain activities, and that's certainly something to be aware of. Okay, so those are the actors who the information blocking rule applies to. What information does the rule apply to? Because it can't apply to every single thing that one of those actors holds. So ONC defines the information that is under the information blocking rule as electronic health information, or EHI. And so first, that is a 2-part definition, basically. And the first part is something familiar to most of us in the health IT space, and that is electronic protected health information, and that's that HIPAA term, protected health information, in a designated record set, also as defined by HIPAA, and that's generally that record set that your institution or your organization shares when you get a release of information or something along those lines. But there's a big but. It does not depend on whether that actor is subject to HIPAA. So generally, when we talk about business associates and covered entities, and that would mean hospitals and those organizations that support them, for example. Those entities are generally understand EPHI and how that works. As ONC has defined this definition is more broad. So even if you are not a business associate or covered entity, if you are in possession of these of this data and you are a health IT developer, for example, then you will also be regulated by the information blocking rule. And I think that's kind of in line with this expansion, even beyond HIPAA, to bring more people in line to the regulation to make sure that all of those various stakeholders in the ecosystem are regulated and playing fairly. One final note, just that last bullet there is to say that the data elements that are required right now are limited and are limited to the US CDI elements, the US core data set for interoperability elements. And then in May 2022, ONC is intending to expand that to the entire designated record set. Okay, so that was a lengthy overview, but let's go into, because this is targeted at healthcare providers, let's go into determining whether or not your organization might be a healthcare provider and for purposes of information blocking. And as you see from this lengthy list here, the definition is quite broad. So it does include our kind of classics like the hospital or healthcare clinics, ambulatory surgical centers, But also note that pharmacies, labs, others like the therapists are all covered in the definition of provider. So it's important to know whether or not your organization fits within that definition. Okay, so we talked about actors, meaning who are the organizations that might be covered by the information blocking rule. And we've also talked about what data might be covered by the information blocking rule, or rather is, and that's electronic health information. All right, so we know if we're being regulated, and we know what information would be regulated. Now, what constitutes information blocking? What would be an activity that would be likely to meet the definition in the rule and could lead to liability for our organizations? Well, that definition comes from, as Mel mentioned, the Cures Act. And the Cures Act defines information blocking as a practice that is likely to interfere with the access, exchange, or use of electronic health information. And the reason that I highlight those access, exchange, or use of health information, that it's very important to note that ONC understands the complexities of the health IT ecosystem and understands that interference can happen, and we all know this as participants in the healthcare community. This interference can happen at all levels. So it could be just an outright refusal to give information to a stakeholder who needs that information. It could be using a very esoteric coding methodology that no other system is able to decipher, or it could be charging through the roof fees for simple data and just makes it so you basically are not going to look for that data or seek that data because it's simply too expensive. All of those various activities are the types of interference that ONC is looking to stop. And so it's important to note that it's not just when we're talking about doing an analysis of how this rule applies to our organization, it's not just to say, okay, well, do I look at who can access frontline or let's look at our basic ROI procedures or release of information procedures. It's much more an in-depth analysis of, are your technologies compatible with industry standards? Are you sharing in standard message formats that can be digested by other systems? All of those questions are going to be the ones to ask when you do an analysis to determine whether or not your organization is engaging in activities that might lead to an information blocking claim. Okay, so now that we've defined all these various elements of information blocking, I do just want to note a difference in the intent requirements to determine violation of a rule. And specifically, there's a difference between healthcare providers and health IT developers of certified health IT, like HIEs such as Health Current. And the primary difference are these underlined in red here. When you're talking about the information blocking rule and its application to healthcare providers, there is a higher bar requirement that the healthcare provider must know that the practice is unreasonable and likely to interfere with access, exchange, or use. That contrasts with what the mental requirement for health IT developers, who must know or should know that the practice is likely to interfere with access. So there's a little heads up from ONC that ONC is aware that the health IT developers probably are more likely to engage in information blocking, and therefore they've lowered that bar to say, if you should have known that this was going to cause this interference, then you may be liable under the rule. Okay, so we've talked about all of these various requirements. I know it seems now, you might be saying to yourself, oh my goodness, do I need to be sharing, totally rethinking all of my processes and changing up all of the way we share records? And those are definitely the good questions to be thinking about right now. But what we're going to talk about right now are the exceptions to the rule and the exceptions to that would allow an organization to engage in information blocking and do so in compliance with the regulations. So, as Mel mentioned earlier, there are two groups of categories that would allow you to defend against an information blocking claim. The first is if an action is required by law. So that means that if there's an explicit requirement by state or federal law saying that you may not share information, this might be something like a court order or something along those lines, then you are not required to share that information. And that's relatively intuitive. As you see here, that first bullet though, note that things like patient authorization or consent is not an interference required by law. We're going to get into where those fit into within the regulatory safe harbors. But just know if there is a legal requirement that mandates you not to share information, then you do not need to share that information. Now we move over into the more complex area, and this is where Mel's going to spend the majority of the remainder of our time going through each of these safe harbors. And these safe harbors are the mechanisms by which an organization can conduct an analysis, and we're going to go through each of these complicated analyses, and determine whether or not their activities, one, fall within that may be interference to that access, exchange, or use of information, but importantly, they will ask, but are we doing that activity to meet one of these 8 exceptions? And that will be the root of what an organization will do in order to engage in compliance with this rule. How do you look at your activities as an organization and comport with these exceptions? And if they don't, how do you need to amend your activities such that they do? So Mel, do you want to help us walk through these regulatory safe harbors now?
Yeah, I'd be happy to.
I'm realizing now that we had one other, just to note, sorry, I didn't mention the compliance structure, but just in terms of how that works, the Office of Inspector General, which is a department within the Department of Health and Human Services, is the agency that will enforce the information blocking rule. As you see there on that first bold red, civil monetary penalties of up to $1 million per violation could be assessed. So that's definitely certainly something to be aware of. And then finally, the OIG for healthcare providers will refer providers to appropriate agencies for disincentives. So that means that if you are a provider, you may not be enforced against and get one of these civil monetary penalties, but it could certainly implicate certain funding mechanisms that you get through CMS or others to the extent that OIG finds you in violation. And then finally, you see there that last red highlight that on November 2nd, 2020 is the compliance date. And that is our current target right now. That may change, but that is when compliance will begin for that, as we mentioned, that first US CDI element. So Mel, do you want to start taking us through the exceptions, and we can maybe see if we have any questions from the chat while you're going?
Yeah, that sounds great. Thanks, Case. So Case kind of gave you the nuts and bolts of what an information blocking claim looks like. So we know that if our organizations are actors, so a healthcare provider, and you're engaging in a practice, so an act or a mission that is likely to interfere with the access, exchange, or use, very broad, of EHI, you could possibly implicate the information blocking provision. And if you're acting with a requisite level of intent, you could potentially be in trouble unless what you're doing is required by law, which means explicitly required by law, or you fall within one of these 8 regulatory exceptions. And I kind of refer to them as safe harbors. And what ONC has told us is that if your practice that's interfering with the EHI can fall within one of these 8 regulatory safe harbors, you're guaranteed to not be found to have been information blocking. So the OIG, if you are a healthcare provider, will not refer you to the appropriate agency for disincentives. And if you are a healthcare provider that's operating in HIE, and many healthcare providers, especially large systems, do, or you're not a health IT developer of certified health information technology, or you are, you won't get potentially penalized up to those $1 million per violation. And that's why it's worth taking a look at your practices that affect EHI and seeing what you need to do to qualify for one of these 8 regulatory safe harbors. And there's a lot you have to do to qualify for these safe harbors. Each of these has a number of conditions that you have to meet. A lot of them overlap and work together. And I'm going to do my best to try to present these safe harbors in a way with examples so you can understand how you're going to apply them to your healthcare practice. And what I'm going to do is I'm going to start with the preventing harm safe harbor. Then we're going to talk about the privacy safe harbor and the security safe harbor. And then I'm going to go a little bit out of order in terms of how these safe harbors are presented in the rule, to talk about this content and manner safe harbor that we got with the final rule, but we didn't have in the proposed rule, and talk about how that works in conjunction with this infeasibility safe harbor, fees and licensing safe harbor, and then also a little bit of information about this health IT performance safe harbor, which isn't as important for healthcare providers as it is for HIEs, for example, and health IT developers of CHIT. So let's go ahead and talk about the preventing harm safe harbor. So this one's really important for healthcare providers, and ONC took great care to make sure that it aligned with the HIPAA access rules to allow providers to continue to deny partially or entirely access to electronic health information if the healthcare provider has a reasonable belief that that interference is going to substantially reduce the risk of harm to a natural person. Really important here to keep in mind that we're talking about people like you and me. We're not talking about organizational harm. If you're worried about an organizational harm, we're going to have to look to another safe harbor, like maybe the security safe harbor, to cover that practice. But in order for this safe harbor, the preventing harm safe harbor, to apply, not only do you have to have this reasonable belief that your denial is going to substantially reduce the risk of harm to a person, you also have to make sure it's tailored, so no broader than what's necessary to reduce the risk of harm to the person. So a good example of this might be if in your electronic medical record you have information about domestic violence that your patient might be facing. And let's say there's a patient access request. She's requesting access to her medical records, but you're very concerned because you know her partner, who you suspect of domestic violence, is going to be looking over her shoulder or is going to have access to these medical records. And you're fearful that if you disclose that information in her medical record to her, that she's going to get hurt by her abuser. So in that circumstance, you could absolutely interfere with this access request by a patient and say, okay, I'm not going to give her this component of her medical record because I believe that holding that back is going to substantially reduce the risk of harm to her. But it has to be narrowly tailored. You can't tell a patient, well, I'm not giving you your information out of your electronic medical record. I'm going to deny your access to all of it because of this. You would have to take the time to withhold that component of her medical record that you believe is necessary to reduce the risk of harm to her. It's also important to keep in mind here that we're talking about a very specific legal definition of risk of harm. It can't just be risk of harm of anything. It has to fall within one of two buckets. And for healthcare providers, it's the first bucket that I think you're going to look to most often. You have to make a determination on an individualized basis by somebody who is actually a licensed healthcare provider and who has a past or current relationship with the patient whose EHI is at issue. And that's different than HIPAA, right? HIPAA, when you deny a patient access request, doesn't necessarily require that relationship between the patient and professional. You could have maybe an independent professional come in and do the analysis. That is not the case with the information blocking rule. This professional who, for instance, decides to hold back the information in the medical record about domestic violence has to be a professional who's either treated that patient in the past or has a current relationship with the patient. So it's important to keep in mind if you want to qualify for this safe harbor. Additionally, there is a risk of harm component if what you're worried about is more of a technical concern, where you're worried that the data, you either know or you reasonably suspect that there's mismatching going on. Like maybe Mel Solis and Melissa Solis got crossed, and you're worried that the data is now corrupt, and you don't want to disclose the data in response to somebody who's asking for it, like maybe another healthcare provider, until you can fix the error. But again, if you're going to withhold data because you're worried about mismatching or data corruption errors, if it only applies to one patient, for instance, and not the rest of your patients, when you're getting an access request maybe from another third-party personal health record vendor who's asking you for data for patients, who's given them authority to ask it, you can't use there being an error for one patient to deny errors with respect to other patients unless you think that this mismatching or technical error is happening more broadly across patients instead of just for, Mel or Melissa Solis. There's also a type of harm component here, unless you were worried that this was not complicated enough. It's not enough that there's just a risk of harm. It has to be a certain type of harm, and that type of harm either has to be a substantial harm or a harm to the life or physical safety of a person. And the level of harm we're talking about really depends on the nature of the requester. So when you're going back and you're looking at your HIPAA access policies to amend them to fit your access denial request, to fit within the safe harbor, what you're going to want to do is make sure that your policy or procedure addresses the level of harm you have to reach depending on who's doing the requesting. And the reason I'm suggesting that you go back and update your HIPAA access policies to do this is another criteria of qualifying for this safe harbor requires you to meet a documentation element. You either have to have that written organizational policy, or you have to make a fact-specific determination on a case-by-case basis every time you're interfering with an access request based on this preventing harm safe harbor. And I think for most providers, whether you're in a practice group or in a large health system, it's really hard to meet a documentation requirement on a case-by-case basis. It's easier to rely on your organizational policies that say when you're going to deny access requests. And if you're a HIPAA-covered entity, you should already have this because you're required to have your HIPAA privacy policies in place. And you can just simply amend them to make sure you meet these other requirements of the preventing harm safe harbor. Also for healthcare providers.
So Mel, it sounds like we have in fact entered the tornado of the information blocking world as you give us this great analysis of just one of the 8 exceptions here. I think it's clear just how complicated this is in terms of what an organization will be thinking about when they look to compliance. So I do just want to mention for everyone who is maybe experiencing something like that and saying, oh my goodness, how again am I supposed to absorb all this information? Again, what we're trying to do right now is give this primer, but I do want to make sure everybody is aware that we're going to be producing additional content that Mel is going to actually help us be going into much more depth, and to the extent that we can continue to provide those resources, we'll certainly look forward to doing that. Mel, while I'm here, I did want to just ask a quick question we got in the chat, and that was with regard to if there's any specificity that ONC lays out to when an actor needs to respond to a request. So in the chat box, it said, does the request need to be answered within 24 hours, within a week, et cetera? So do you happen to have any insight on what an actor might do to kind of analyze that question?
Yes. So the timing component depends on what safe harbor you want to use or have available to you. So under the preventing harm safe harbor, if you wanted to rely on this one and you got an access request, the preventing harm exception doesn't actually have a timing component to it. However, under the HIPAA access rules, if the request is coming from the patient or the patient's personal representative, which is usually the context in which you would look to the preventing harm exception to deny an access request, HIPAA does have timing components, and if you're a HIPAA-covered entity, you have to respond within 60 days to that individual access request. Now, let's say you...
Go ahead, Mel.
I wanted to say, well, let's say you're getting a request for access from somebody else, maybe an HIE or another third party, and it's not an access request where you're going to deny access because you're worried that the patient's going to get hurt. In that instance, if you were going to deny the access request based on an infeasibility ground, and we'll get to the infeasibility safe harbor in today's presentation, you would have to respond within 10 business days and tell that person that responding to that request is infeasible. Same is true also under the licensing safe harbor, and we'll talk about that a little bit as well. If you wanted to take advantage of a licensing safe harbor because you want to impose licensing terms on somebody's access to your EHI, you have to meet the time frames of that licensing safe harbor, again, if you want to take advantage of it.
Great. Well, thanks, Mel. That's really helpful. It's helpful to understand a couple things to know from your response there, that when you are conducting this analysis, you're really not just looking to the information blocking rules. So HIPAA and other rules that may apply to your organization may have a relation to your information blocking compliance. And so that's just something to note, as you mentioned, the patient access rule and things like that, what an actor should be assessing when they conduct this analysis. Okay, so sorry, I didn't mean to distract us there. Do we want to move into our next privacy exception?
Yeah, that's actually a great segue. Let's move into the other safe harbor. Boy, this is a big one. It's actually 4 sub-safe harbors or 4 sub-exceptions. We could easily spend an hour on this one alone. But what I really want to focus on is the first safe harbor, preconditions not satisfied, because what that safe harbor is really intended to do is to tell us all, healthcare providers, HIEs alike, that you still need to comply with the privacy laws that apply to you. Like HIPAA, might be 42 CFR Part 2. If you're an HIE, it might be Arizona's opt-out requirements. And that if a precondition of the law is not satisfied, that would allow you to give the requester who's asking for access to that PHI because you haven't been able to verify their authority, or there is not an authorization or consent on file and the law requires it, your denial of that access request isn't going to result in an information blocking violation if you follow the steps required for meeting the conditions of this safe harbor. And a lot of this is similar to kind of what we talked about with the preventing harm exception, and you're going to see this again and again. You can deny access because a legal precondition was not satisfied, but your denial, again, it has to be tailored to the actual legal precondition. And I'm going to use 42 CFR Part 2 as an example. 42 CFR Part 2, or Part 2 for short, as many of you know, is a federal privacy law that gives heightened privacy protection for substance use disorder information that's coming from or originating from certain substance use disorder treatment providers. And it has downstream restrictions. So even if you are not a substance use disorder provider, if you're getting the Part 2 records from such a provider, they're called Part 2 programs, then you are also subject to Part 2 with respect to that information. So let's say you are a behavioral health clinic. You're a mixed-use facility. You do general behavioral health, but you also have a clinic that does substance use disorder services. It's a Part 2 program. That data is more protected. In a circumstance where you have a patient who has a co-occurring disorder and is getting both services, and let's say one of their other healthcare providers, I'll make it an OBGYN, asks for a copy of their records. They don't send a HIPAA authorization. They don't send a Part 2 compliant consent. They say, HIPAA allows me to have this information for treatment. Please send it over. I need to know this information about mom. Well, the practice isn't going to be able to send over the Part 2 information because it's protected by Part 2, and Part 2 requires a consent for disclosures even for treatment purposes. So in that circumstance, this behavioral health facility, which is a mixed-use facility, could say to the OBGYN, well, here's mom's behavioral health records, but they're not going to send the Part 2 records because a legal precondition has not been met. That's an example of tailoring what you do to the legal precondition that you determine has not been satisfied. And when you do this, the other condition for qualifying for the safe harbor is you have to do it in a consistent and non-discriminatory manner. You can't decide, okay, well, I'm not going to share all of this patient's information with this OBGYN because they're not affiliated with maybe my organized healthcare arrangement. But this other OBGYN over here, I'm just going to give it to them because they're part of my OCA. Not only would that not be permissible under the privacy laws and would be a violation there, that would be an example of you applying the same legal precondition differently, depending on whether the requester has a relationship with you or not. You can't do that. and that's a theme that's going to be throughout these safe harbors, is the intent behind ONC, the intent behind Congress, is to take these anti-competitive reasons for not sharing electronic health information out of the equation. And again, and you're going to hear me say this quite frequently, in order to qualify for this safe harbor, you're going to have written policies and procedures in place that specify the criteria that you're going to be looking for if you're going to deny access on there not being a Part 2 consent, for example. You either have to do that, and you have to train on it for your workforce members, or you have to document on a case-by-case basis why you're not giving over the data. To go back to the Part 2 example, for instance, if you're going to deny access because, let's say you got a HIPAA authorization from that OBGYN, but you get the HIPAA authorization, you're like, this isn't good enough under Part 2 because Part 2 requires this special type of consent, and I don't see those requirements to meet the Part 2 conditions in here. I'm going to deny it. If you're going to do that, you actually have to have your written policy spell out what those Part 2 requirements are and why you're denying on that basis. Or if you're doing it on a case-by-case basis, so you don't actually have that written policy, you'd have to document in the patient's medical record that the reason you didn't give access is because it wasn't a Part 2 compliant consent, and why. The other thing that you're going to have to do in order to qualify for this exception is if you're denying it, the access request, because what you got in terms of the consent or the authorization does not meet those legal requirements, under this safe harbor, you have an affirmative obligation to, pick up the phone and call that OBGYN and say, this isn't sufficient or release for the information that you've requested. Or if it's Part 2, what you would have to do is you'd have to pick up the phone and contact the patient and say, hey, I got this request from your OBGYN. It's not compliant with the Part 2 purposes. Did you want to disclose your substance use disorder information that's protected by Part 2? And if yes, here's the form that you have to fill out, or here's how you fix it. Having to take this additional step is something healthcare providers have never had to do under HIPAA, but now it's something that you have to do if you want to qualify for this safe harbor. So that's really all the time we have today to spend on this one component of the privacy exception. I want to now quickly run through the rest of the exceptions, unless Chase, did you have a question, or were you going to raise something?
No, Mel, I think you've done a great job to really show the complexity and how, going through that stepwise process is really how organizations are going to be able to best address the information blocking rule. I would just say for the audience, one thing to note, and you see these are the 4 conditions for that one privacy exception that Mel alluded to, the legal precondition not satisfied. But I think the bolded words are kind of ones to be thinking about as you're thinking about applying any of these safe harbors, and things like tailored and consistent and non-discriminatory, specific, reasonable. Those are the types of themes that are really going to be woven through all of this analysis. How can you have tailored, non-discriminatory, reasonable restrictions on the sharing of your information? So that's just kind of a thing that I think is something to hold on to from this presentation is those are the themes, and then we're going to continue to talk about the specificity, but just wanted to kind of highlight those. So yeah, let's get into the security exception now.
So the security exception is ONC's attempt to recognize that there are going to be practices where you deny access to EAQI either partially or totally for a temporary period of time if it's necessary to protect the security, integrity, and confidentiality of the electronic health information and our systems that are holding the electronic health information. ONC does not want to sacrifice those practices. But again, in order to qualify for this exception, what you're doing has to be directly related to protecting the EM information. It has to be tailored to that specific security risk. Again, implemented in a consistent and non-discriminatory practice. And you're either going to need to document why you're doing it on a case-by-case basis, or have it covered in your organizational security policy. Because most healthcare providers are HIPAA-covered entities, I think it makes the most sense to update your policies for consistency with these exceptions ONC does not actually give us a lot of examples of when this will come into play, and I think they did that because it's mostly common sense. One example they do give us, though, is in many instances, there might not actually be a law, for instance, that requires you to verify the identity of the person who is requesting access to EHI, but we all know that that is a best security practice. You want to know that the person who's requesting the information is who they say they are. And those type of practices make sense. ONC wants to encourage them, but if you do it, make sure that you're asking everybody to verify their authority, and you're not giving preference to certain third parties who you might have a business relationship with. A really good example of this might be personal health record mobile applications. There's a lot of them out there. If you're not already getting requests, you will start getting requests from third-party mobile applications who are saying, I'm a personal health record who's acting on behalf of the patient. Please send me their EHI. If you're going to verify that they are in fact acting on behalf of the patient, and you should under HIPAA, you're required to know that they are actually a designated person, and there is technology that's being developed out there to do it in a way that's HIPAA compliant. If you're requesting that level of verification from one third-party mobile application company, you better request it for that other third-party mobile application company that maybe you've invested in or that you're part of a joint venture of, because again, we need to do things in a non-discriminatory manner. So that's a little bit of information on security. Let's talk about the content and manner exception. This safe harbor, we did not have it as part of the proposed rule. We got it as part of the final rule. And ONC's intent here is for this exception or safe harbor to act as a funnel for application of other safe harbors, particularly the infeasibility safe harbor, the licensing, and the C safe harbor. So I'm actually going to talk about all of these together, and you have details on all the slides. So the way the content and manner exception is set up is it starts with this obligation that actors need to fulfill a request for access to EHI in the manner that it's requested, unless, and there's two unlesses, unless you're technologically unable to fill the request. For example, you get a FHIR API request for EHI. You're not set up to deal with FHIR. You're technically unable to fulfill that request in the manner that it's requested, okay? The other unless is unless you cannot reach agreeable terms with the requester to fulfill the access request. So let's say you're contacted by a PHR vendor, so a personal health record vendor, one of those third-party mobile application companies, and they say they have, 100 requests on behalf of all of these different patients of yours who want to get their records, and you are just not technologically set up to handle that volume of requests. Well, under the information blocking rule, if you're trying to reach agreeable terms with the requester under like fees and licensing, so you can build out the resources in order to respond, but you can't reach agreement with them, then you can qualify for this safe harbor, but you have to go the next step. So if you determine you cannot respond to a request for EHI in the manner that the requester is requesting it because you're technologically unable, or you just can't reach agreeable terms with them in order to fulfill the request, you now have an obligation, if you want to qualify for the safe harbor, to respond to it in an alternative manner. And on the technology side, there's actually an order of priority for how you can technologically fulfill the access request. So look to the rule for that on that order of priority. And if it comes down to this is an issue of you guys not being able to reach agreeable terms to satisfy the request, well, you can look to the fees exception and the licensing exception, or you can look to the infeasibility exception. And Chase, if you could take us to the next slide. The infeasibility exception is going to be really important for, I think, all actors. And this exception is recognizing that there are going to be practical challenges for your ability to comply with any given request for access to EHI. It could be infeasible, and you can qualify for this safe harbor if one of three circumstances apply. Either we're talking about uncontrollable events like a natural disaster or a public health emergency like COVID-19. For example, if all your resources are tied up in responding to COVID-19 requests, you could qualify for this safe harbor because it might be unfeasible for you to respond to the access request because of the pandemic. That's an uncontrollable event. The other infeasibility condition might be segmentation. You can't, for instance, pull apart your Part 2 records from your non-Part 2 records. So you might get that treatment request from the OBGYN for access to a patient's records for treatment purposes, but you can't even give them access to the non-Part 2 general mental health information because your information is so entwined that you can't do it without having that Part 2 compliant consent. And then lastly, it just might be infeasible under the circumstances. There's a whole bunch of factors you can consider. You have to document it. There is a documentation requirement, and you have to be able to respond to that actor within that 10 business day time period to tell them that it's infeasible for you to respond to the request. But you do have an option under this factors-based circumstance test to say, for instance, to that PHR vendor who's requesting all of these records and you're not set up to facilitate it, that I don't have the financial resources and capabilities because I'm a healthcare provider, I'm not in the data exchange service to respond to your access request. So that's how infeasibility works. The next two exceptions, fees and licensing, I'm not going to spend time on a lot in this webinar because I don't think it's going to come up so often for healthcare providers. We are going to do a series of pre-recorded webinars that's going to do a deep explanation of the fees and licensing exceptions. But the idea behind these is ONC recognizes that there are business reasons why you want to put conditions on how EHI is accessed and used, and as well as fees to recover the costs of providing data exchange services, for instance. And you can do that level of interference, imposing conditions, imposing fees, so long as you meet the requirements of the safe harbor, again, assuming that you want to qualify for the safe harbor or qualify for any of these safe harbors. I want to emphasize here that just because you engage in a practice that implicates the information blocking provision, and just because you might not do something right and maybe not qualify for all of the conditions of these exceptions, does not mean that you will have been found to have violated the information blocking rule. You still have to be acting with the requisite level of intent. And the last exception that we have up here is the health IT performance exception. This really comes into play more for health IT developers of CHIT and HIEs, where they need to be able to take their systems down in order to do updates, to do maintenance. You can do that and still qualify for the safe harbor. But again, in order to do that, you have to meet various conditions like being non-discriminatory, be consistent, getting agreement in advance with the people that you're providing these services to, that you're going to bring their system down. And again, we'll do a more in-depth webinar on that one to the extent any healthcare providers are offering their own system to others. On this last slide, we've given you some details or some ideas about how to implement compliance for your organization. It's important to do this now because the compliance date is November 2nd, and it's going to take time to identify your practices that might implicate this rule and figure out what you need to do to change those practices or update your policies and procedures so you can qualify for these safe harbors that we've talked about. So my suggestion is get your team together. If you already have a compliance team, which for large health systems, you probably already do, and for larger practice groups, but even if you don't, create a compliance team, identify an organizational leader who's going to lead it and take responsibility, and identify the practices that your practice is engaging in that might implicate information blocking, assess them, and then figure out what you need to do for organizational compliance. And what that's probably going to mean is updating, in some cases, creating new organizational policies and procedures. After you do that, you're going to want to train your workforce members on those policies and procedures. Implement a complaint process so people can tell you if they think you're engaging with information blocking before they go and report it to ONC. And just like your HIPAA compliance, November 2nd isn't a stop date. It's the start date. This is going to be an ongoing thing that you'll need to do in order to monitor, investigate, and enforce compliance. And throughout this process, you might find that you actually need to go back and amend some of your contracts or agreements that impose restrictions on access to EHI in order to comply with the information blocking rule. And before we let you leave today or open the floor for questions, I did want to spend a little bit of time talking with you about the CMS COP's conditions of participation ADT alert requirements. Chase, could you go ahead and move us to the next slide? So along with the information blocking rule, CMS also published its own interoperability and patient access rule that has certain requirements for health plans, which we're not going to talk about today, but also healthcare providers. There is this May 2nd, 2021 compliance deadline for hospitals, including psychiatric hospitals and CAUS, that participate in CMS programs and that have these electronic medical or administrative systems that can support HL7 2.5.1 content or higher, basically meaning you're participating in the Promoting Interoperability program and you have the ability to send ADT alerts. To be able to send certain ADT alerts to certain recipients by this deadline. Importantly, however, though, if you're a hospital that doesn't meet these technical requirements, these COPs are not going to apply to you. Also, with sending these ADT alerts, you're not required to use CHIT. It doesn't have to be a certified health electronic IT solution to send them. So what are these new CMS ADT alert requirements? There's triggering requirements for emergency department and inpatient registration or admission, as well as discharge or transfer to the ED or the inpatient. The minimum content you have to send out is patient name, the sending institution, so the hospital name, and the treating practitioner name if permitted by applicable law. There might be instances, especially if you're a psychiatric hospital or a general hospital that operates a Part 2 program within your facility, where you might not be able to send all of these data elements because of Part 2 restrictions. You're not required to send them under this new CMS rule if you would not be able to under the privacy laws that apply to you. What's also nice is these ADTs have to be sent electronically, but they don't specify the method, so you have some flexibility here. You also have the flexibility of designing your ADT alerts to also meet requirements of the 2019 CMS discharge planning rule and also maybe your requirements under the Promoting Interoperability program. So you can do that. In other words, you might as well kill two birds with one stone. The other requirements for ADT alerts are that you're only required to make reasonable efforts to assure that these ADT alerts are getting out to the patient's applicable post-acute providers, PACs, that the patient might be transferred to, as well as the patient's established primary care physician. And the good news here is you can use an intermediary like HealthCurrent to get this done. As many of you know, HealthCurrent already offers ADT alerts. We can customize systems to meet ADT alert requirements. And here is a list of all of the participants in HIE, which include ACOs and clinically integrated networks, who then pass down ADT alerts to their participating providers, as well as direct alerts that go out to PACs directly and behavioral and community health providers. So that's just a little bit of information about CMS ADT alerts and the fact that HealthCurrent also participates in something called Patient-Centered Data Home. What that means is if a patient has an ADT alert with a zip code that's outside the state of Arizona, which, you know, happens quite frequently because we do have a lot of snowbirds here, it will actually get sent out to an HIE gateway that's associated with that away zip code, so that that information, that ADT alert, is passed along to that patient's home HIE and gets off to their home care team. And that's really important for compliance with the CMS ADT alert requirements, because with this ADT alerts, it has to go out to their primary care physicians, right? There's no geographical boundaries within the CMS rule. So if the patient's primary care physician is in Michigan, that ADT alert you need to make reasonable efforts to get that off to that provider in Michigan, and leveraging PCDH connections like this one is one way to do that. All right, I know we're close to the top of the hour. You might have questions. There might be questions in the chat box. I'd be happy to stick around and answer those.
Great, thank you, Mel. And this is Chase here again. I just want to say, with regard to the CMS rule and the ADT requirements, please feel free, if you are a hospital or one of those other entities who are under those requirements, please feel free to reach out to either me or your health current account manager. As Mel did mention, transmitting ADPs is really kind of germane to what we as an HIE do. So we're more than happy to work with your entities to see how we can facilitate you meeting those requirements. Okay, so Mel, as we're in our last 2 minutes here, I just wanted to look at a couple questions we had in the chat box. So the first one, and most of them are related to information blocking, so we just got about a minute left and we can answer these couple. So first is, the question was posed, is it considered information blocking if a fee is charged to access or share PHI from a third-party commercial application? If a fee is acceptable, does the fee need to be charged to all entities requesting information?
So charging fees could implicate the information blocking rule. Does it violate the information blocking rule? That's going to depend on the circumstances in which that fee is charged. So remember that content and manner exception, where if you can reach agreeable terms with that person, to that commercial vendor, to provide the EHI in the manner that they requested, and if you can do that and you qualify for that safe harbor, you don't have to worry about complying with the fees and licensing safe harbors. So what that means is, with respect to that specific transaction, you might not need to worry about whether the fee you're imposing meets the fee's safe harbor. However, we all know that we can't always work out those deals, right, with commercial vendors. Sometimes we're unable to reach agreeable terms. And under that content and manner safe harbor, if you find yourself in the circumstance where you can't reach agreeable terms and you still want to qualify for a safe harbor because you don't want to be found to have information blocked, well, then you are going to have to comply with the fees licensing exception. And for that particular exception, you do have to charge, for instance, the same fee to all substantially similar classes of requesters. So that doesn't mean you have to charge everybody the same fee to qualify for that safe harbor, but if they're substantially similar and they fall within the same class, then in order to qualify as one of the conditions for that safe harbor, you would have to meet that. And there's lots of other conditions
Right.
to meeting that safe harbor. And that's one of the reasons why we're doing a separate module, just to go through all of those conditions and what ONC has told us in the preamble to the final rule about how to apply them.
Great. Well, thank you, Mel. Okay, well, again, everybody, we're right at the top of the hour. Thank you so much for some great questions and for sticking around for our presentation. As we've said throughout, this is going to be the first, this is our second example of the same webinar, but our first example of a whole variety of content that we intend to produce to facilitate you and your organizations to comply with the information blocking rules. So please keep an eye out on the Health Current website or Health Current alerts to be apprised of what's upcoming. And again, please feel free, as you see our contact information on the page right now, please feel free to shoot either Mel or me an email if you have any more specific questions, and we're happy to either answer those or work those through the processes to get you answers to those questions. So with that, I think we can go ahead and end the session, but as Mel mentioned, we can stick around. If there's anybody who would like to stick around, we're happy to chat and potentially set up any calls or whatever communications we need to going forward. So thank you again for attending, and we'll look forward to seeing you at the next similar presentation. Thanks.